Hi, my name is Hunor Kertesz, and if you would like to know about my project Effect of Time of Flight on reducing the injected 18F FDG activity for whole body PET-CT imaging of pediatric oncology patients, then stay with me for the next 10 minutes. This presentation was meant to be presented at the European Congress of Radiology in the beginning of March in Vienna. However, due to the current situation of the spread of COVID-19 virus worldwide, the whole conference was moved online. The project is a collaboration between the Medical University of Vienna, where I am a PhD student in a team called QIM, which stands for Quantitative Imaging and Medical Physics, with the Children's Hospital at Westmead in New South Wales, Australia, and the University of Sydney in Australia. The aim of this study is to evaluate the effect of time of flight at low count levels in case of whole-body pediatric oncology patients, since we know that the injected activity leading to the effective dose administered to the patient is really important in case of pediatric patients. So first, let's talk about time of flight. As we know, in PET systems, we are detecting two photons which are emitted from the patient's body, and they are forming the line of response, but we don't really know where exactly these two photons are coming. In newer systems, which are equipped with time of flight capability, actually we can measure the T1 and T2 time of the arrival of these photons, and based on the time of flight timing resolution of the systems, we have a much better localization of the annihilation points of these two photons. In previous studies, it was shown that the signal-to-noise ratio for the time of flight is actually proportional to the diameter of the patients, meaning the bigger the patients, the higher the benefit of time of flight it is. However, in our case, we were focusing on pediatric patients, which are actually much smaller than an average adult. In this study, we've been using the data of 29 patients, all of them who underwent 18F FDG whole-body PET-CT examinations with an injected activity around 150 megabecquerels plus minus 50, which means that actually an activity concentration was around 4 plus minus 1 megabecquerels per kilogram. In our case, the used system was a Siemens Biograph MCT PET-CT system, which has a time of flight resolution about 500 picoseconds. We wanted to simulate low count level. For this purpose, we were acquiring the data in list mode format, and to virtually simulate low count levels, we took the original list mode data, we assigned random numbers to each event in the list mode, and then by applying a threshold, we deleted all the events in the list mode data which had a random number assigned above our threshold, and we just kept the values assigned which were smaller for every event. And in this way, we've been generating new list mode dataset for our analysis. For every single patient in the study, we generated 5 new list mode datasets ranging from 10 to 75% of the original amount of counts, and then we did the reconstructions with the vendor tools, in our case the E7 tools. First, we've been using the OSEM, the Ordered Subset Expectation Maximization algorithm, then the OSEM algorithm with time of flight information added to it. Third one was the PSF, which is an OSEM algorithm with resolution recovery, PSF standing for point-spent function. And finally, we've been also using the PSF algorithm with time of flight information added to it. Since we wanted to be really close to the clinical scenario that is used day by day, we also added a 5mm full width half maximum Gaussian post filter to every image. All these combinations were leading in the end to 24 set of images to be analyzed for every patient in our study. As a figure of merit, first we were defining the signal-to-noise ratio, calculated as the mean value in the volume of interest divided by the standard deviation in the same volume of interest. Then we were also calculating the SNR gain, which is basically the ratio between the SNR in the time of flight images divided by the signal-to-noise ratio in the non-time of flight images. And finally, we've been also calculating the noise as a standard deviation in the background divided by the mean value in the background. As we know, different image reconstruction algorithms have different convergence, and in order to come up with the right settings for our purpose, we picked 3 patients randomly from our cohort, and we did the reconstructions for all the 4 different reconstruction techniques, starting from 1 till 8 number of iterations and 14 subsets. For all the cases, we calculated the contrast as the mean inside the lesion divided by the mean in the background. In the background, we were always focusing just on the liver. So we have been looking at the contrast versus the number of iterations, as well as the mean value versus the noise, as you can see here in the background. And based on these analyses, we came up that for our purpose, the most suitable settings for the image reconstructions would be 5 iterations, 14 subsets for the known time-of-flight reconstructions, and 3 iterations, 14 subsets for the time-of-flight reconstructions. Looking at the results, just visually, we picked one of the patients who had 2 lung tumors shown by the arrows, and in the top line are shown the PSF reconstructions ranging from 100 down to 10%, and on the bottom line are the PSF TOF reconstructions from 100 down to 10%. In this case, we don't really see a big difference when we go down to 50% of the original amount of counts. However, when we go below that, like 45 or at 20 at 10% of the original amount of counts, the images became way more noisy. When we compare the PSF to the PSF TOF recounts, we can see that the PSF TOF images are much smoother, but we really need to pay attention on the details to notice the real differences between them. Basically, also at 35% of the counts, the images look really similar to the original images that would have been acquired and used in clinics. As it was also shown in previous studies, that the bigger the patient, so the SNR gain is actually proportional to the diameter of the patient, basically meaning that we can go with the BMI, and then we can see the same trend in our data. So basically, when reducing the counts down to 50%, still the SNR gain is increasing, basically for all cases, for PSF versus PSF TOF, as well as for OSM versus OSM TOF. However, when we go down to 35 or 20 or 10% of the counts, we induce so much noise in the images that actually we lose the benefit of time of flight. When we were evaluating the noise levels in the images, we can see of course that PSF TOF is performing the best. But what is interesting, if we compare images reconstructed with OSM at 100% of the counts with the images reconstructed with PSF TOF but using only 35% of the counts, we obtained similar noise properties. But what was really important for us, we wanted to see how low we can go with the injected activity. So we took the ENM dosage card and calculated the ENM recommended injected activity values for every single patient, which is defined as a baseline activity with a multiple based on the patient's weight. So in the background with the blue bars, you can see what would be the 100% of the injected activity recommended by ENM, with the green bars would be the 75% of the ENM recommendation, and with red in the bottom would be the 50% of the recommendation by ENM. However, the blue line actually corresponds to the injected activity that actually was used for these patients, which is interestingly corresponds to around 75% or even below ENM recommendations, which would mean even below 50% of the ENM recommendation. And just if we would reduce to 75% of the actual injected activities, this would be at 50% of the ENM recommendations. Finally, we also want to know how usable the images are for the clinicians, since based on our analysis we could reduce down to 50%, but the really important thing is that the clinicians are able still to use these images to perform the diagnosis. In order to evaluate this, we asked 3 nuclear medicine physicians to evaluate and rate our images. So we took all the images reconstructed with PSF TOF at 100, 75 and 50% of the counts. We anonymized completely the data and mixed them together. We sort them into 3 different days for 3 different reading days, and also in between the days we mix them the order of the patient. So on day 1, for example, the reader doesn't know at what images it's looking at. It can be the 50, the 75 or the 100%. On day 2, for example, the first patient on day 1 would have been patient 7. On day 2, the first patient might be patient 11. In this way, we were trying to eliminate everything that the readers cannot remember which case corresponds to which patient. And we provide only the minimum necessary information for all the readers in order to be able to make a diagnosis. All the readers need to fill in a questionnaire where they need to rate the images on a 5-point scale, starting from very poor to optimal. In between every reading day, we actually have minimum 1 week apart from each other in order to reduce the possibility that the readers can remember the cases from the past. In conclusion, the injected activity can be reduced if the suitable image reconstruction is selected or available depending on the system. The benefit of time of flight is not really seen at really low count levels, since we induce so much noise in the images that we lose the benefit of time of flight, and in the end the clinical evaluation that I just presented a slide before needs to be done, since it's really important that actually the clinicians can use still the images. Finally, I would like to thank the Ocean Science Foundation for supporting our project, and I would like you to thank as well for your attention. If you have any questions, please just write it down in the comments, or if you would like to keep your question private, then you can write me an email on the email below, and I will make sure to answer all the comments and all the emails. If you are interested about my other projects or the projects of my colleagues, then you can check out the QR code which is leading to our website. And for now, that's all from me, and see you in the next one. Bye!